Hello friends, welcome back to my channel. So today I'm going to discuss one of the most important topic of MCCQE1, that is the lower back pain. As we all know that the lower back pain can be acute or it can be chronic. How do we differentiate between them? If it's less than 4 weeks, then it is usually acute. If it's between 4 weeks to 12 weeks, it's sometimes subacute, or if it's more than 12 weeks, it's usually chronic. So today I'm going to talk about the simplest lower back pain first in an acute situations. This is not regarding to the patient's age, this is not regarding to patient genders, but it is in general situations. Whenever a patient come to us with the lower back pain, we think of few symptoms to make sure that they are associated with patient's pain or no. So number one is any signs of infection, fever, urinary symptoms like incontinence, bowel movements, any neurological weaknesses in the extremities, especially the lower extremities I'm talking about. And if there any history of exertional work, it could be twisting of his body for working purposes, or it could be lifting heavy objects if working long hours in a standing position or something. And do we have a tenderness of the paraspinal regions? So let's say if we have a simple back pain, no complication like this, as well as patient is having some exertional work at her occupation, or as well as they might be doing something extra. Let's suppose someone says we are relocating from one place to another, so that is more work than they normally do. And on examination, if you feel the tenderness on the paraspinal regions, but your test, which is we call straight leg raise test, is negative, then our diagnosis usually starts with the simplest one, that is paraspinal muscle strain or ligamentous strains. What are the basic features we can see in a patient with this? If patient is having any lambosacral strain, then the patient will be having paraspinal muscle strain, any tendon, any intervertebral column, ligament problem, sudden or imbalanced muscle contractions. Risk factors would be obesity, spinal deformity, degeneration, muscle weaknesses. What are the clinical features we can see if this is the simplest form of the patient is coming with the pain in the lumbar region? It could radiate to the buttocks, hip or thigh, but it will never go beyond knee. We just have to remember this. If it is not beyond knees, that means it is the sprain or strain. Paraspinal tenderness could be positive. There will be no neurological deficit. That means the patient does not have any sensory problems in the extremities. Patient will not have any reflex problems, and their straight leg raise test will be negative. But one key important point is when you will be doing the straight leg raise test and the patient is having aching pain, you need to ask a question: is the aching pain going to the heel or the foot, or it is just above the knee? If it's just above the knee, that means we don't consider it as a positive straight leg raise test. Okay, what additional workup? As we all see, it is a non-complicated lower back pain, acute situation, could be because of exertional activity, so we don't do any investigations. Now what we do to treat the patient? So number one thing is, we always say that patient, you need to have doing your routine activity as normal. You don't have to restrict yourself. Definitely we won't say that okay, keep doing the same exertional activity you were doing, but they can walk, they can sleep properly, they can do their job, they can do all the activities, cooking, bathing, everything. They don't have to worry about anything. Secondly, first line drug is NSAIDs. Second line drug is non-benzo muscle relaxant. I'm going to discuss this management options in little details into my first page. So first of all, we always say non-pharmacological, then we come to the pharmacological situation. So in non-pharmacological, it is important that we say to maintain the normal kind of moderate activities. We don't say that you have to rest, you have to stop your activities. No, We always say keep doing whatever you are doing, just don't do the exertional activity. We tell the patient about the activity as well as tell that it will gradually be going down. You don't have to be worry about the prognosis. Second thing, heat, massage or acupuncture or sometimes spinal manipulation could be helpful for time being. If these things are not helping, patient is still coming back with the pain, start with NSAIDs. First initial drug is NSAIDs or acetaminophen. We don't go with any kind of heavy. How severe the pain is, it does not matter. We just have to make sure that we are starting with some NSAIDs or acetaminophen. What are the second line drugs? Second line drugs is start with some muscle relaxant that are non-benzo. Let's say cyclobenzaprine. Or if patients come back after taking every step from this chart and they still says, oh doctor, I have a lot of pain, then we could go with opioids or tramadol, but these are not our initial or first step. It was only done when we have a severe pain or refractory kind of pain in the patient. So this was all about lower back pain in an acute situation of any age due to exertional activities. There is a one tip is NSAIDs can be used as first line for acute uncomplicated lower back pain. If NSAIDs are ineffective, we can give non-benzo muscle relaxant, which can be like cyclobenzaprine, or this one can be provided additional pain relief. But we can do massage, heat, acupuncture, normal activity and everything goes on. Now my next topic is lumbosacral rediculopathy. As we all know, the initial topic which I read is just about lower back pain. There was no urinary symptoms. There was no symptoms up to the foot. There was no lower extremities pain or any type of aching situation. But in this condition, you will be getting all the symptoms, but not always. We always think about lumbosacral rediculopathy with the urinary symptoms, with the bowel problems, with the saddle anesthesias, with the pain up to the heel. But is it always present? No, it's really present. Let's talk about lumbosacral rediculopathy, which is called the acute back pain. Definitely it's an acute, but it is some kind of a more serious, or we can say more painful. What are the common causes you can see in a patient which come with the lumbosacral rediculopathy? And definitely how can we distinguish lumbosacral strain from lumbosacral rediculopathy? Common causes could be herniated intervertebral disc. Herniated intervertebral disc could be acute. Yes, it could be acute. Nerve root compression will definitely happens, or the patient is having any degenerative spondylosis. Patient is having malignancy or epidural abscess. All of these situations could lead to LS rediculopathy. What are the signs and symptoms we see in patients? Pain radiated down posterior to the leg of the foot. We remember in the first topic, we says the pain will never go to the lower extremities below the knee, but here it can go up to the foot. Dermatomal sensory loss or the myotomal weakness could be present. In that scenario, we could not find it. Straight leg raise test positive for the pain up to the back of the foot. It could be L5, S1, something that depends upon the involvement of the lumbosacral spines. But the patients complain with the pain of foot when you do the straight leg raise test, or we might do the cross leg raise test. Okay, rarely, if any central posterior dislocations causes cord compression, then patients will come with the upper motor neuron lesion along with bladder or bowel dysfunctions. That's what I was talking about. Rarely, whenever patient is having central posterior dislocation, that leads to compression, that can lead to bladder and bowel. But if it's lateral side, there is no problem in the bowel or bladder problems. But definitely SLR test will be positive and sensory or the myotomal muscle weakness will be there. How do we evaluate? For sure, MRI is one of the best. But do we need to do MRI always? No. MRI is not recommended in an uncomplicated cases. That means you have clinically diagnosed a case, but patient does not have these features. You don't have to do it. You just have to treat, because either you do MRI or you don't do MRI. There is no change in your treatment options. Significant bilateral neurological deficit. If patient is having neurological deficit that is either bilateral or either it is a significant in a patient, then we can go with the MRI. If a patient is having evidence of bladder or bowel dysfunction or sudden anesthesia, we can do MRI. If patient is having malignancy suspicious or epidural abscess suspicious, it's an abscess, sorry about that, suspicious, then we do the MRI. But if all of these things are not available, do we do MRI always? Not always. It depends upon case to case. What are the high risk features in a back pain which suggest that the patient might be having an infection or malignancy, or they might need MRI? Where if it's cauda equina syndrome, we know that the patients will come with the acute urinary retention, sudden anesthesia. If a patient is having epidural abscess or spinal infections, patient will have fever, suppression, any kind of, or IV drug users. Malignancy, any recent or current malignancy is there, because it is possible that if a patient is having any other malignancy, then the bone metastasis has happened. So in that scenario, patient is high risk, we do MRI. Or the unexpected weight loss, that means going to the indication of malignancy anywhere else into the body. Other features are, as we all know, if there's a weakness but that is very severe, that is either bilateral or progressively very fast. Focal spine tenderness, coagulopathy, or patient age is more than 50, because in more than 50 years of age, if it's female, they go to the osteoporosis, and that leads to the vertebral column compressions and everything, or maybe fractures. So that's why we do MRI. How do we treat this? The most important question is, how do we treat this? So if I go to the topic of how do we treat this, so we treat with a situation called same as we did in the first one, lumbosacral strain. Activity modification is definitely the same. We just have to tell the patients, keep moving, don't bed rest. There is no short-term or long-term bed rest is recommended nowadays for any kind of lower back pains. First 1 or 2 weeks, you can definitely start with NSAIDs, acetaminophen, ibuprofen or something. After 2 weeks, if patient is still feeling pain, go with the physical therapy and go with the oral corticosteroids if you feel that the patient needs it and there is no contraindication for that. After 4 to 6 weeks, if patient is still having pain and the patient is saying that pain is getting worse, if you haven't done MRI before, do the MRI, do the assessment if the patient is having a good indication to go for surgeries. So this is all about acute situation with the simple lower back pain as well as the complicated, or we say the most severe form of back pain, that is the radiculopathy. Thank you, and I hope you enjoy this video. If you have any comments or you would like to get these notes, I can definitely share with you. Just put the comment and I would be more than happy to share this